Cameras on? Yep. Okay. Great. So I want to welcome everyone to Pediatric Grand Rounds. Ottawa is built on the unceded Algonquin and Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land, as well as all First Nations, Inuit, and Métis people. Our grand rounds today are from a group of four senior pediatric residents, and I think I've just read their bio. I'm joking that the bio is the shortest and pithiest one, and it's actually got the relevant information. So I'll read it out to you. Brittany, Joey, Sasha, and Emily. So Brittany Bishop, Joseph Kate Rose, Sasha Palmert, and Emily Poole are all senior residents in the pediatrics residency program at CHEO who love sleep, babies, and when babies sleep safely, and probably themselves too. So I think actually with that, I'll hand it over about the ABCs of safe sleep.
Perfect. And we have two of us in person, myself and Brittany, and two of us are scattered across the city and also in Nunavut. So Joey's at the Civic this morning post call, so be kind to him. And Sasha's up in Iqaluit on her northern rotation. Joey, are you there?
Yeah. Hi everyone. I'm joining from a call room, so apologies if there are any overhead pages. But yeah, as introduced, our Grand Rounds is on the ABCs of safe sleep. Uh, Next slide. I don't think I can control them.
I'm gonna try. There we go.
All right. So the objectives of our Grand Rounds presentation are to review the principles of safe sleep for infants and to understand the context around the development of safe sleep guidelines here in Canada, to examine how safe sleep recommendations are implemented inside of pediatric hospitals and at CHEO specifically, and then to discuss the cultural consideration and systemic barriers around safe sleep and how to engage in harm reduction and safe sleep counseling. Next slide. So to begin with, we have to think about what actually is safe sleep. And so the goal of safe sleep is to promote infant well-being and to reduce the risk of injury or death, and especially sudden infant death syndrome in infancy. And so safe sleep involves several components. It involves where the baby sleeps, what position they sleep in, what bed or crib they are sleeping on, and then the environment around them and their sort of home and sleep environment. Next slide. And so current Canadian safe sleep guidelines focus on those four things. And so in terms of the location, recommendations are for room sharing with caregivers for the first 6 months of life, but discouraging bed sharing where caregivers and infants are in the same bed. The position is always to be supine, so babies are to be put on their back for all sleeps, including naps. The bed should be firm and flat. There should be no gaps, no loose items. And then Health Canada actually has a page of guidelines with very specific details on how cribs, bassinets, cradles should be constructed, inspected. And even if you buy a used crib at a lawn sale or a yard sale, Health Canada's guidelines are supposed to apply, and you're not supposed to be able to buy an unregulated crib. And finally, there's the environment the baby sleeps in. And so ideally, babies are breastfed in a smoke-free home and should be in comfortable sleepwear without a risk of overheating. Next slide. And so the reason for safe sleep guidelines mainly is to reduce the incidence of sudden infant death syndrome, or SIDS, which is the unexpected death of a healthy child less than 1 year old occurring during sleep. We know that there are some protective factors for SIDS: sleeping on the back, room sharing with parents, breastfeeding for at least 2 months, and pacifier use. We know that there are unmodifiable risk factors, and so that's young maternal age, prematurity in the infant, low birth weight in the infant, and a family history of SIDS. And then we have modifiable risk factors, which are exposure to tobacco smoke in the home, bed sharing with caregivers, and an unsafe sleep environment. And you could also say positioning for sleep. Next slide. And so a question when we get here to the current safe sleep guidelines is how did we get here to the supine for every sleep evidence and position? And so in North America and Europe, early in the 1900s, the recommendation was commonly for supine sleep. Beginning in the 1950s, in some very popular mass-produced parenting books like Dr. Spock's books, uh, pediatricians and other influential people started encouraging prone sleeping. And then beginning in the 70s, a definition, in the late 60s and the 70s, a definition comes out for SIDS, and statistical evidence starts to mount that prone positioning and eventually that side positioning seems to be linked to SIDS. And in the late 80s, the Netherlands becomes the first country where the medical societies begin to actively recommend against prone positioning when putting babies to sleep. So, next slide. And so, how did that then shape the Canadian context? In 1993, the Canadian Pediatric Society published its first statement on reducing SIDS, recommending either back or side sleeping in a smoke-free environment. And it has since gone on to recommend only back sleeping, now that side sleeping has also been found to be associated with SIDS. And then in 1999, a nationwide public awareness campaign was started called Back to Sleep and now has been changed to Safe to Sleep with ads throughout doctors' offices. There were posters put up in McDonald's. There were public service announcements on TV about putting your baby to sleep on their back and maintaining a safe sleep environment. It was an extremely effective awareness campaign. In 5 years, the SIDS incidence in Canada dropped by 50%. That said, SIDS remains the leading cause of death for infants 1 to 12 months in Canada, and the SIDS incidence since 2004 has pretty much plateaued. And populations within Canada, especially Indigenous communities in Canada, continue to face a much higher incidence of SIDS than non-Indigenous communities. Next slide. And so this is Health Canada statistics on the SIDS incidence over time in Canada. And you can see the blue line at the top is post-neonatal mortality, all post-neonatal mortality from 1 month to a year. And the black line is deaths that were then classified as SIDS. And we can see that starting around, for SIDS specifically starting in 1990, there's a gradual decline from about 1 per 1,000 to about 0.5 per 1,000 that has stayed pretty much the same from 2005 until 2010. And the more recent data shows it's still pretty much the same. Next slide. And so how does this compare globally to other countries? With an important caveat that comparing SIDS deaths across countries can get quite challenging. SIDS classification and diagnosis requires a considerable amount of post-death investigation that isn't available or isn't done identically in every single country in the world. And then how each individual country classifies unexpected infant deaths is also different. And so you'll see that some deaths in some places that are classified as SIDS can also be classified a non-SIDS diagnosis could be something like ASSAB, which is accidental strangulation or suffocation in bed. And so you end up with a bit of a statistical challenge in comparing across countries. But looking at this table, which compares some common comparator countries to Canada, such as Australia, the States, some Western European countries, Japan, and Argentina, we can see that from 1990 to 2005, all countries had a significant drop in both their post-neonatal mortality rate and also in their SIDS rate, all of them being around 50% declines. Next slide. And so looking first at the graph on the left, this is the same information as that previous table, but a little bit more up to date. And it's the SIDS incidence in a number of comparison nations. We can see Canada's is around 0.15 now, and pretty comparable to Australia, Japan, Germany. And some of the differences seen, like America's higher rate, are suspected to be attributed to statistical differences in classification and not necessarily a true difference in incidence. And then because Australia is a very common comparison country for Canadian statistics, this is a similar graph to that one from Health Canada, but for Australia after they reduced the risk campaign, which started in 1990, which shows a similar sudden and sustained drop in SIDS incidence. Next slide. And so, what is SIDS like in Canada today? The Stats Canada released a statement in 2021 examining SIDS over the previous 5 years, found that 70% of cases occur in babies less than 4 months old, and almost all of cases involve infants who are in an unsafe sleep environment, normally with multiple risk factors present, either a surface not intended for sleep, bed sharing, or side or stomach lying. Next slide.
A natural question that comes up after learning that it's not recommended for people to bed share is why do people then bed share? So this was based off of some information from a Canadian Health Survey in 2015 and 2016 that looked at what were the reasons that people were choosing to bed share. It looked specifically for those that had an infant that was less than 1 year old and that had been born in the past 5 years, so from 2010, 11 to 2016. In those people, 33% reported bed sharing frequently, 27% had bed shared occasionally, and 40%, only 40% had never bed shared. When they asked what some of the reasons for bed sharing were, they mostly mentioned breastfeeding, but also facilitating better sleep for both mother and infant. But it was noted that there was definitely a difference among different cultural backgrounds. So for people living in Canada, if they were from an Indigenous population, there were higher rates of bed sharing compared to non-Indigenous populations in the territories. Also, infants of mothers that were born to people from Asia, South Central America, and the Caribbean had higher rates of bed sharing than those whose mothers were born in North America. So, for example, there's 57% of mothers born in Asia had bed shared at least once versus 27% of mothers born in Canada. So important to acknowledge that there's definitely some cultural differences in those who choose to bed share, and that cultural background might play a role in the decision to bed share for some families.
Okay, we're going to switch gears a little bit to look at safe sleep in the hospital because this is where we spend as residents the majority of our time. So here's just a couple of cases to think about, and we'll come back to them, but just to kind of get your brains going. So you can go back to your resident roots if you're not there right now. So the first one is you're seeing a little baby, 23 days old, in the Emerge who needs admission for fever at 3 a.m. And so when you go, you walk into the room, everybody's asleep, mom, dad, baby, and baby is lying on their mom's chest while she's on the stretcher. There's no crib in sight. The second one is daytime hours. You're reviewing your little toddler who has bronchiolitis before morning rounds. Maybe you're a medical student, and you notice that their overnight nurse left a note in the chart that the parent had requested a bed for their child instead of a crib. And when you go into the room in the morning, you find the parent and child asleep in the bed together. And then the last one is another little toddler, 18 months old. You're getting him ready for discharge after you treated him for a cellulitis, and unfortunately he falls out of his crib, breaks his femur, ends up needing a surgical repair and a prolonged hospital admission for pain management. So just keep these in mind. We're going to come back to them in a couple of minutes. So what's out there easily accessible for parents to find when their child is admitted to the ward at CHEO? There's not a whole ton. This is what I found from just doing a brief search on our website. So you can see at the bottom here just some brief recommendations for sleeping safely in the hospital. So these include the crib side rails need to be raised at all times, the fact that CHEO as an institution does not support co-sleeping arrangements between parents and children, and then just the guidance that children should not be sleeping in the bed chairs, which if you've been on the ward, you are familiar with the bed chairs. Doing a little bit of a deeper dive, this is what I came across with the help of the nursing staff on the ward. So they're the ones who are the most familiar with it. But we do actually have a safe sleep policy for children who are admitted to our general peds wards. So these are just a few of the highlights. So basically on admission, kids who come upstairs need to be assessed for safe sleep requirements. So you're looking at things like the age of the child, how big are they, what's their developmental stage and ability. And so you're trying to find a suitable sleeping arrangement that will be safe for them on the ward in considering all of these things. And then you can see 2.4 at the bottom here references our CHEO policy against co-bedding. So this is like explaining bed sharing arrangements between a parent and a child are not permitted. And then we'll go to the next slide to see kind of what our responsibilities are from the healthcare side of things if parents are wanting to go against this policy and what kind of steps need to happen. So generally, and as outlined in the policy, and as we all who spend time on the ward know, lots of this falls on to our nursing staff. So there's certain responsibilities that nurses have when it comes to safe sleep. So they need to provide a fair amount of education to families and to let them know outside of just what's available online, those brief like 3 lines, what our sleep policy actually is and what the expectations are for children who are sleeping on the unit. And so the bottom part that I've outlined here is what needs to happen if, like in our second case, there's a family that's requesting an alternate sleeping arrangement aside from what's recommended by the nursing staff for their child. So nurses are required to document all the teaching and all the education that they give the family around safe sleep and why it's important and why our policy exists. So lots of the stuff that Joey mentioned in the beginning of the presentation. And then they also need to escalate, if parents are still wanting to proceed, they need to escalate to whoever is in charge, whether it's the charge nurse or a manager or ClinOps. And then finally, they need to document exactly what happened in the patient chart and what the outcome was. And they also are supposed to file an incident or a safety report, so known to us as SRSs, if the ultimate decision of the parent is to proceed with their co-sleeping. So these are our cases, and I'll spare you the participation, but just start thinking a little bit about what some of the factors are that may be compromising safe sleep in this situation. So this is our little tiny baby in the emerge in the dead of night, sleeping on their mom's chest on the stretcher. So a couple of things that we had thought of that are kind of unique to this setting and unique to the hospital that might be interfering with our ability to implement safe sleep policies are the time of night. Much less likely to be thinking about safe sleep at 3 a.m. than maybe you are at a more reasonable hour. Parent illness and fatigue. How often do we see children whose parents are bringing them into the hospital and they have the same viral illness that their child does and they also haven't slept in 48 hours? Again, it's maybe not top of mind when parents aren't feeling at their best. Obvious in this one is a lack of available equipment. So if there's no safe sleep equipment, aka a crib for a baby, in this case, how are you going to be able to participate in safe sleep practices? So that's a big one. And then another big one that we see often in the hospital, this is in the emerge, this is in our ICUs, this is on the ward, is that parents want their children to be as comfortable as possible, especially when they're sick. And often this looks like sleeping with their child or having their child sleep on them. And then, as we all know, this is not unique to the emerge, but there's resource constraints. I really doubt that for the nursing staff in the emerge at 3 a.m, the thing that's top of mind is safe sleep. I think they probably have other things on the go. So if there's not kind of these policies that are built in, then it's not necessarily going to be something that they're thinking about as they're trying to do a million other things and trying to keep everybody safe. So this one is the little toddler whose parent wanted to bed share and they had bronchiolitis. So we'll see some similarities and some differences. So this one in particular is a big one, and I don't think it's unique to CHEO, but uncomfortable parent sleeping arrangements. So our favorite bed chairs. It might just be that parents find those too uncomfortable, and their reason for wanting to sleep with their child is so that they can actually sleep in a bed. Not that the stretchers are a whole ton better, but that could be something that is contributing for sure. What their preferences and what their usual practices are. Often parents will try to simulate what they and their family do at home to try to make a strange and scary environment a little bit more comfortable for their child. Discomfort around safe sleep education. So this just depends on who is providing education and guidance to the family when they arrive on the ward and how comfortable people are in doing that counseling. Are they familiar with the guidelines? Have they counseled before? Do they feel like that's part of their role? That's all going to play a difference in how much education actually happens for these families. And then, like I said, it's not unique to the Emerge that there's nursing time constraints. There's a million things that our nurses are running around doing. And sometimes counseling about safe sleep and providing that education might fall lower on their list. And then again, this is kind of universal across the board. Parents just want their kids to be comfortable. There we go. Okay, and then this is our last one. This is our little guy with the broken leg. So this one's a bit different than the others, but is a true story and definitely has happened. So in this case, using equipment that's not familiar or is clunky and difficult for parents to use is a big risk here. It's just different than what parents are used to at home. And I've been here 3 years and I still don't know how to work all of the beds and cribs in the hospital. So that's definitely relatable. And then in the same vein, just a lack of parent education. If you don't take the time to educate them about how to work the crib and that there's 2 different stopping points and like you got to pull up and squeeze at the same time, then parents might just be left with these questions and wondering how to best use the equipment that's available to them. Improper cribs for a child's size is a big one, especially if we think about our kids who spend long periods of time at CHEO who actually do grow and develop a lot during their admission. What might have been appropriate in terms of sized crib for them at the beginning of their admission might not be anymore. And so if we're not constantly having those check-ins as children are growing, we might find that they're outgrowing their cribs, and then that leads to accidents. Broken or faulty equipment, it's hard to get away from this, but like flagging things when you see something that's not working properly is super important. And then we're all aware of this parent or healthcare team fatigue, forgetfulness, distraction. We've all, heard it from a nurse when we forgot to put the side up of a baby's crib after we're done examining them. It's a stressful environment. You're often doing more than one thing at the same time. And for parents as well, you're trying to look after your kid and keep everybody safe, but there's often lots of competing priorities.
Just to supplement some of the things that we already talked about, this is a research paper that also identified some of the barriers to safe sleep in the hospital from 2023. So from some of the organizational level, we've already talked about lack of time, lack of education of staff, having a lack of resources, and a lack of physical space as well. On the individual level, some of the factors that may contribute are staff belief and compliance. So if staff co-sleep with their children at home, then they may be less likely to say something to a parent who is doing that with their own child. Discomfort or distress of the patient. It's really hard to tell the parent of a very fussy child that they need to put them back down on their back properly for sleep. And then perceived conflict with other recommendations. So for things like skin to skin and our management of GERD, we always say to keep them upright, and the things that we may recommend at times don't always seem, there may be a perceived conflict with our safe sleep guidelines. There's also cultural barriers like we talked about versus like family beliefs, but also language barriers at times, like having to get the translator out at 3 a.m. to counsel about safe sleep can be challenging. But things that they found to be enablers of safe sleep were having positive role modeling by the nurses and also having increased education. Well, role modeling by everybody, but mostly the nurses.
So how are we doing in terms of our safe sleep in the hospital? There's actually very limited evidence from our Canadian context, but there's fair bit more from the States. And generally, when they look into this, they see fairly low baseline adherence to our safe sleep guidelines before intervention. So these are just a couple of different papers. This one from Batra and colleagues in 2021. So they found at baseline, head of bed flat was only happening in 62% of cases. A sleep space free of extra items only about half the time, and babies were only on their back about 81% of the time. Macklin and colleagues, this was 6 centers, I think, out of Ohio, and they just found that there was only about a third of these bed spaces that were following the AAP recommendations, which is like their equivalent to the CPS guidelines that Joey was explaining earlier. And then Carabello in 2023, this was just a single center assessment, but it's quite striking. They found prior to their intervention, there was actually 0 crib environments that they looked at that fully met the AAP recommendations, and that only 12% of cases had documentation of parent education around safe sleep environments. There's a little bit of data from London. This is really all that I could find, and it was kind of around their implementation of their safe sleep program, which is not super clear about what that actually is. But statistics from London found that safe sleep position, so back to sleep, only about 3/4 of the time, did improve to over 90% with whatever implementations they made. And then loose items in cribs 80% of the time, which I think anybody who spends time on the ward believes that. There's always stuff in the baby's cribs. Did decrease to about 40% with their intervention. So that's all that I could really find from our Canadian pediatric centers. In terms of looking at our data at CHEO, it's minimal. We had the safety reporting people prepare some data for us. And I think this is from the last year. So these are all of the SRSs that were submitted related to inpatient sleep or co-sleeping on the ward. So this, if you think back to the policy, it's supposed to be that anytime a parent is requesting alternate sleep arrangements and wants to co-sleep with their child, the nurses are supposed to document and also put in an SRS. So we can see this is just from the last year. There's only 8, which I think anyone who, again, spends a fair bit of time on the ward I was surprised by this. Like, I know that this happens more frequently than 8 times in the last year. And we also asked them to look back further than that, and there was no reports in the years prior. So I think it's relatively new that we're even reporting these at all, and definitely a big area where we could improve so we get some of our own data, because without data, there's not really anything we can do to work towards improving it.
So the next couple slides are talking about what are some practical things that we could potentially implement that would help improve safe sleep at the hospital in a number of different settings. This is one tool that I found that was recently validated in January of 2026 this year. That is a tool that's supposed to be used at the beginning of every nursing shift to help remind people to evaluate the safe sleep environment and the different factors that contribute to this. So the slide on the left, this is sort of like the supplemental material that nurses have access to if they want to go and look for more details of what qualifies as safe sleep. And then the tool on the right is something that would be like embedded into a flow sheet on Epic or something that's at the bedside that nurses can go through at the beginning of every shift to see if we're meeting these criteria, sort of as a reminder to make sure that we are checking in on these things. But then at the bottom, it also talks about safe sleep teaching for parents. So it asks, was teaching done if safe sleep wasn't being followed, and why was that, which also can help prompt to sort of look into why it might not be happening, what we can do to improve that, and also would sort of prompt SRS reporting as per our policy if it's noted that it's not being followed. So it's been validated as a tool. It was looked at across 28 different centers, but is new and upcoming, so still needs some further research into it. This is a paper that looks specifically at safe sleep in the NICU. One of the reasons this came up, and probably also something that people in the NICU have seen, is that I have at least said before, we keep the head of the bed elevated for the baby as long as possible to try to prevent GERD and make sure that they're tolerating their feeds. And then right before we go home, we put their bed flat, and we're like, never do that again at home. Like, now they have to be safe, they have to be completely flat. We can't raise their head of bed, which sometimes can be contradictory information that parents are receiving. So this was a study in 2015 that encouraged safe sleep practices for any patient that was over 34 weeks corrected gestation and over 1,800 grams that didn't have any other medical complications that would preclude them from participating. It was mainly a nursing education web-based module that was completed, as well as in-person teaching sessions for the nursing staff. But it also involved having a flip card on every bassinet or crib that said we are either practicing safe sleep or we are practicing standard NICU practices. So it was a visual reminder as well to flip over the card if we were able to participate in safe sleep. So having those two things together did significantly increase the amount of safe sleep that was happening in the NICU, which just goes to show that it is possible to incorporate it earlier if we're staying on top of it and there's education about it, which can help model that behavior to parents a little bit sooner so that they get used to that and are more likely to implement it at home as well. Safe sleep in the PICU is complicated for a number of different reasons. This paper looked at what some of those reasons are, but included not always being feasible with certain conditions and procedures, like for patients that are intubated and need to be proned. There are lots of reasons we can't follow safe sleep initial guideline recommendations. Patients are often sedated for long periods of time, so they need to be repositioned. And sometimes one of the things that we justify to parents is like, well, they're on a monitor, we're continuously monitoring them, so we would see if there was any changes to their heart rate or to their oxygenation. So that helps to reassure us. But then naturally for parents that then go home, they say, well, why don't I just get a monitor so that I can also monitor them at home? And then maybe it's not as necessary or important for me to practice those same sleep policies if that's what was happening at the hospital. So just to chat a little bit about home oxygen monitoring for babies specifically. So there are a number of different technologies that are available for parents to monitor both oxygen levels and also heart rates at home. They are usually advertised as needing something to complement safe sleep practices and to be used in association with safe sleep practices also. But something that can happen is that there can be an over-dependence on these monitors to catch things that they may not necessarily be catching as well as we think, and can also cause unnecessary anxiety if they're constantly ringing off and having false alarms, which can cause parents to have alarm fatigue as well and may not take them as seriously if there is an issue. So currently there is no monitor that is commercially available that's approved by the U.S. Food and Drug Administration, Canadian Ministry of Health, and the Canadian Pediatric Society to help prevent SIDS and warn that those could lead to a false sense of security and increased risk of suffocation. We also have research from CHEO, from Dr. Kovesi's team, that talked about how the available commercial monitors for infants specifically are not very accurate for infants under the age of 1, which is the population that we're specifically concerned about for SIDS. There's also a huge variation in the number of products that are available. So in 2023, there were 48 different products that were available on Amazon, and finding research on any of those specific monitors is extremely difficult. One of the most common ones that parents often have or may have heard about is the Owlet sock. There is one research study that the Owlet sock company sort of points towards for the validation of their monitor, where it was compared against an FDA cleared pulse oximeter that would be used in a hospital setting. And the findings of that study were that it detected hypoxemia inconsistently. Sensitivity and specificity for the hypoxemia monitor was 88 to 85%, but for bradycardia was 0 to 100%. Which somebody pointed out to me is the same as a regular sock. Like, basically not helpful for bradycardia. And that's sort of like the best study that we have looking at one of these monitors.
So what can we do to help families participate in safe sleep in the hospital? A few things that we've already mentioned. So education is really the biggest one. So everybody that's patient-facing, no matter your role, should feel comfortable and confident discussing safe sleep with families, or at the very least should feel comfortable and confident directing them to someone who can answer their questions. Consistency, like Britt had mentioned, leading by example in the hospital is really important. If we consistently demonstrate that we feel safe sleep principles are important, the hope is that that's going to spill over into the home setting. Whereas if we keep babies at a 75-degree angle until the day before they go home, we might leave parents wondering why on earth we're doing that and why it's important that they do it differently. And then equipment. So this is more so on a hospital level. Having functional, age-appropriate, and easy-to-use equipment for patients and families should be a priority for us as an institution.
Just going back to that, something recently that had come up sort of around end of December this year was a fundraising campaign that CHEO was doing specifically to raise money to replace the bed chairs. So something that there was definitely some thought and effort going into to try and improve the safe sleep environment in that way.
In terms of what we can do practically, I think lots of this presentation has had messaging about, what are the responsibilities of our nursing staff. I think it's important to think more broadly than that and know that we all have a role to play in encouraging safe sleep. So if you see something that makes you feel like, ooh, this doesn't look great from a safe sleep perspective, say something. Check with a parent, check with a nurse if you feel like safe sleep arrangements could be optimized. And then for those of us who order things or who are going to order things in the future, trying to limit unnecessary monitoring and interventions like lines and tubing can also be a way that we can promote safe sleep. Like Britt had mentioned, with the monitoring, it's not the be-all, end-all. Accidents happen even on monitors. They're not perfect, and it does give us that false sense of security. So if it's not necessary, don't order it. And then include safe sleep in your routine discharge counseling and instructions. I think we're pretty good at doing this in the NICU side because everyone is a tiny baby and going home for the first time generally. I think we're less good on the ped side, and there's definitely room for improvement in terms of our routine counseling for anybody who's going home and getting discharged, to include a brief section about safe sleep.
One more intervention that is something to consider is how residents specifically can get more training about being more prepared to participate in safe sleep counseling. This is a simulation that was created for senior residents to help them practice having some of these difficult conversations or what can be perceived as difficult conversations while trying to incorporate some of the additional challenges that may come up in those situations. So in this specific simulation, it's speaking with a family who is from a Burmese community who does not speak English, so using a translator who may have had like cultural practices of bed sharing in their family. So it basically walk through how you would have that conversation and allows people to practice having those kinds of conversations in a low stress environment, and then scored to see how residents perceived how well they felt prepared to have those conversations, as well as engaging in conversations with family from diverse patient populations. And it seemed like the residents felt that it was valuable in that sense. So just a way to show that this can be something that can be taught and can be practiced and can be incorporated into simulation-based medical education.
Sasha, do we
Okay.
hear you? There we go.
Yeah, I think you can hear me. Yeah. Sorry, my internet connection is not the best, so I'm going to leave my camera off. But the last part of our presentation is just looking at some of the systemic barriers that exist to safe sleep to keep in mind for when we're providing that counseling for parents or going home. And then some of the cultural considerations. So if you look at SIDS disparity both globally and within Canada, and Joey showed us some comparator countries earlier, even within Canada, there's quite significant discrepancy in terms of SIDS outcomes. And this was true across those comparator countries as well. So when you look at like the US, Australia, or New Zealand, there is quite significant disparity within certain populations that have much higher rates of SIDS. In Canada, the population that is most impacted by this disparity are Indigenous populations. There's not a ton of recent data, but there's actually pretty good data from the 2010s that highlight this. Two of the studies that I found that really outlined it in the most clear way was one from Manitoba, which was a 10-year review, so looked at SIDS deaths from 2009 to 2018, and used the Canadian classification of SIDS deaths. And in this, they found that in Manitoba, Indigenous infants account for 20 to 30% of live births in that period, but they accounted for 85% of SIDS deaths. So obviously, that's a significant overrepresentation of that population. And then Nunavut did a similar 10-year review a little bit earlier, so from 1999 to 2011. They looked at infant mortality more broadly compared to Canada, but SIDS was the leading cause of infant death in Nunavut in that time. And the infant mortality was 3 times the national average and 2 times the average of the Northwest Territory, so a comparator territory. The outcomes were worse. And if you look at the graph that is at the bottom of the slide here, this is from that study from 1999 to 2011, and it looks at the different causes of infant death in Canada as a whole country when compared to Nunavut as just a territory. And you can see that in Nunavut, SIDS is a larger percentage of infant mortality than would be expected in Canada as a whole. Next slide, yeah. So why do these disparities exist? We frequently cite cultural differences in terms of reasons why there is increased bed sharing or like supine or non-supine positioning or other things that are not within our recommendations for safe sleep practices. And that certainly is true to an extent, but there's a lot of significant practical barriers that we don't always think about when we're counseling to go home from the hospital. So in terms of bed sharing, if you don't want infants to have bed sharing, then the infant needs a designated place to sleep, whether that be a bassinet or a crib or mattress. In homes that are significantly overcrowded with limited availability of sleep services, then there is no designated place for the infant to sleep. And so therefore you have to bed share for everyone to be able to sleep in the home. The picture on the slide is pulled from an article, a news article published that is highlighting the significant overcrowding that exists in many of the homes in Nunavut and in the Inuit communities in particular who are living in Nunavut. And so it highlights one of the practical barriers to safe sleep. They are piloting, so there used to be a infant in a box program where when infant was born in either Iqaluit or one of the health centers, they would be sent home with literally a cardboard box that would be the infant's designated sleep area. And it is recognized in the CPS statement that if there is not a Health Canada approved bed available, then a designated sleep area that is a firm surface, such as a cardboard box, could be an alternative until an appropriate sleep area is available. They discontinued that program and are now actually piloting a bassinet program for infants that are born in either Iqaluit or any of the health centers in Nunavut. And I was speaking with one of the pediatricians who's helped pilot that program up here, and they do find that families are using them. Like when they go to do home visits or home care, the infants are often asleep in their provided bassinets. And they haven't like this that pilot project only started in the last couple of years, so there isn't any data in terms of the outcomes yet. But they anecdotally felt that providing a individual like space to sleep has helped reduce the SIDS incidence that they are seeing. They are not provided to infants that are born in Ottawa. So when we discharge our families from Nunavut or back home, they aren't provided with that bassinet. Other reasons or other systemic disparities that exist, higher incidence of substance use, particularly nicotine exposure. And so it's not just smoking in the home, but if parents smoke and they have nicotine or tobacco smoke on their clothes and then are co-sleeping with baby, then that puts them at higher risk, as well as limited access to prenatal or well baby care, and then educational attainment. In studies that look into factors that have people that are aware of sleep recommendations, adhere to them or not adhere to them, level of education plays is it like a significant role in terms of whether or not people follow the guidelines that they are aware of. Next slide. So from a systemic level, I talked about the bassinet program that's being piloted, and I've been told that the data will be available in the next couple of years to see whether or not that's effective. But there's only 2 pediatricians in Iqaluit, which is the largest center in Nunavut, and anecdotally, both of them have told me that it has made a big difference in terms of the amount of SIDS deaths that they've seen. So they're probably pretty good anecdotal reporters. Other larger opportunities systemic change is obviously addressing the housing crisis that exists within the territory. And so looking at data from 2016, there's a significant number of new houses that would need to be built, and that number only continues to rise as the population continues to rise. You can see that in the whole territory, 38% of families lived in overcrowded homes, but in some communities, that can be as high as 72%. And then the other risk factors, particularly tobacco use, has been targeted specifically. So there's specific, Nunavut has done a specific campaign to help reduce tobacco use for multiple reasons, but this is one of them. And it's highly accessible to get nicotine replacement therapy in any of the communities provided for free at any of the health centers. The other thing that was highlighted is that anything that increases stress within the baby's sleep environment or within the home can be a risk factor for SIDS. So things like substance abuse, domestic violence, food insecurity, et cetera, can all be things that make the sleeping environment less safe. And so tackling any of those issues are good opportunities for systemic change. Next slide. Yeah. So then what can you do when you're counseling individually? It's important to think about harm reduction anytime you're counseling. So the majority of SIDS that was documented in Indigenous infants, both in Manitoba and in the study in Nunavut, showed that 70+% have had 2 risk factors. So even if you can't modify both risk factors, then perhaps you can modify one or some of the risk factors. So for example, if bed sharing is not avoidable, there is some on the Government of Nunavut website. There are some descriptions or strategies for reducing the risk with bed sharing, where you should place the infant on the bed, removing all the blankets that are around the infant in that area of the bed, having the infant not placed between the 2 caregivers, the infant not placed between the mom and another child. So you can make the sleep environment as safe as possible if bed sharing is not avoidable. And then you can do other, like counseling on the other things that can be done. So for example, having the infant always be supine, smoking cessation counseling, discussing the benefits of breastfeeding, providing pacifiers, which are also shown to be protective against SIDS, are all things that you can do from a harm reduction approach as an individual practitioner. Last week was Safe Sleep Week in Nunavut, and so they were providing these handouts for the families that visited the hospital. This is an example of like what the parents were receiving, which is pretty much just a quite simple 7-step instruction with an associated picture. This is the English version, but it was also available in French and in Nutitut. Uh, and there is also on the Health Canada website I focused a lot on Nunavut because we generally serve the families from Nunavut through CHEO, but there are different links for Indigenous created safe sleep guidelines on the Health Canada website that show which territory or province they're from, so they may be more relevant for the like for your specific population. There's a video, I believe, that was made in Manitoba that is made by an Indigenous creator with illustrations that puts safe sleep or talks about safe sleep. So that's another possible resource.
This is our last slide. It's representation from our resident group. This is baby Gavin reminding you not to forget your ABCs. So babies should be alone on their back in a crib. That's the easiest way we can simplify our safe sleep guidelines for families. Thanks for listening. We're happy to take some questions.
Perfect. Great, thank you. So yeah, there were more people who came in while I wasn't facing the back. So any questions from the room? Thanks for that presentation. Yeah.
Hi, great talk. I can't help but be a little bit cynical, and I'm concerned that the emphasis on safe sleep in hospital is not necessarily driven by a desire to protect children, but a desire to medical legally protect the hospital. And I think that the language and the policy around having parents comply, I think comply is a really ambiguous word. And I think that there are potential negative impacts to this and potentially not being family centered. And I just, I'm listening, I understand safe sleep, but when was the last time somebody asked a parent if they're brushing their children's teeth twice a day? And do we have a policy on providing toothbrushes and toothpaste so that every child in this hospital has their teeth brushed by an adult twice a day? And the amount of morbidity that we would prevent with that, I would argue, would make this pale in comparison. So I'm just wondering, like, there's obviously competing interests, but how much of this do you think is driven by medical legal reason and protecting the hospital as opposed to protecting the child?
Yeah, I think that's a really good point. And Britt, you can speak to this a little bit more because I guess just to repeat what Dr. McBride was saying.
Yeah, I was just thinking how to summarize that. Yeah.
Is just pointing out that safe sleep policies and the language that they use, who is actually centered in those policies and whose best interest are we looking out for, that of the children and their families or that of the hospital in terms of protecting against litigation, which I think is a really good point. And Britt, I think one of the studies that you had come across had said that when nursing staff are required to fill out like a form, correct me if I'm wrong, but when they're required to fill out a form, it actually decreases the amount of education that's provided around safe sleep. So it's like emphasis on documentation and that protection piece rather than on education and actual harm reduction. So I think that's a really good point. I would agree that, there is definitely space in our policy and in others to improve the language and the priorities so it's very clear about who we're trying to protect with our policies. Yeah.
So I was trying to go through the chat for questions. Okay, Melissa, you had the first question in the chat actually. So why don't we go with you since you also put your hand up? And we can't hear you right now. I think you're muted.
Sorry, can you hear me now?
Yep.
I think that, I think about in the emerge context of when it is that I bring up these conversations and the reflection that I did about how I had this conversation before I had my kids and then how I had them after I had my first child and then how I had them after I had my second child, who was a very different sleeper. And the tone and the language we use is really important because when you say things like, when a parent chooses not to do safe sleep, like, as an emerge pediatrician who has unsuccessfully resuscitated a child who has died from SIDS, I never chose not safe sleep, but there was different things like when he had bronchiolitis at 5 months, there was no other comfortable position that he was in except for on me sitting up, right? And so some of those things is like, how do we talk about the fact that sometimes, if you have bronchiolitis, you sleep better or you have GERD, and we tell parents to go home and raise the head of the bed up with a baby. So, but I do have the conversation if I know that there are smokers in the home or if they're going home and they're going to be putting the baby to bed in their bucket, for example, or something like that. So I think we need to get at like, what are some of the, like, what is the biggest risk reduction we can do? And so if someone is saying, yeah, they're sleeping in the bed, then I have a conversation about, okay, you're really exhausted. This is when you're most likely to turn around and kind of, fall on your child. So these are some of the things you can mitigate. You can have the side sleeper cot. Like, I think, and if you look at the data, so much has evolved between, the interventions of back to sleep when we had bumper pads and, there was, a lot more smoking in homes. And we have to be careful that, I guess if the baby was well in the NICU at a certain angle and then they're going home, I don't think it's the angle that is causing SIDS, right? If they're on their back in a safe environment and they're able to sleep, because we see the babies who bounce back and emerge, who the parents are like, oh my God, they haven't slept in days, right? So this is more of a commentary, but how we have the conversation and when we use data to say there is still SIDS happening and how can we protect it? Because there's not a family in the world who wants their child to die of SIDS. But, to be able to say, well, your biggest risk right now is how exhausted you are because this is day 4 of bronchiolitis. You're at much higher risk of them rolling off of you or kind of like squishing them. So when you go home, these are the things you need to be careful of. Or, and I would say the same thing in the hospital. If you're having the conversation, it's aligning it with when you see them come in with a big fluffy blanket, you're like, okay, let's have a bit of a conversation about the big fluffy blanket, for example, or and you can anchor it. And I find the reception from families is much better when I can say, well, this is what we worry about, for example. And I really like that you anchored that last part when we say cultural practices. It really depends. If you're sharing a room, it's not cultural so much as that socioeconomic piece. And there um, yeah, and the cultural practice of exhausted parenting is a universal one. So, my thoughts.
Yeah.
Yeah, I think that's a really good point, just in terms of what Sasha was saying. As long as we're engaging with families and having the conversation and not shying away from it because we feel uncomfortable about it, I think taking that harm reduction approach, it doesn't have to be perfect. If there's one thing that we can pick that could be optimized, that could reduce a baby's risk, then let's go with that. It's not all or nothing.
And the last part I would add is that if you look at the data around, it's in deep sleep, and most babies in the hospital are never achieving deep sleep, right? They are inherently protected by the fact that they are never sleeping deeply when they are admitted to the hospital. So, but you can have those conversations with families of like, okay, what is it? And it's not just because you're monitoring them; it's also because of their environment. Like the risk happens with a parent who is in deep sleep, a child who's in deep sleep on an unsafe surface. So I think that helps because then families see where you're coming from.
Mhm.
Thanks, Melissa. Certainly how I approach it also changed after I had kids.
Yeah.
Um,
We're not there yet.
So I think Daniela, the question I paused on here is there's some of these themes coming through the chat. It's a rich chat. But Daniela's question here, breastfeeding and not co-sleeping often doesn't work. Some of the things that Melissa was bringing up as well in different ways. But this is an interesting question. Is there a safe age, quote unquote, for co-sleeping? It's really a risk. And where does the risk sort of start changing in terms of age for co-sleeping? And then do we have a number? I had a couple of my kids were coming up, and in the middle of the night till they were 7, 8, 9, they weren't at the same risk, right? So, where does that happen? And then do we have numbers for breastfed kids co-sleeping with no other risk factors? So both interesting questions.
First one is not really. The only specific age recommendations that we have are about room sharing versus bed sharing. So initially, I think Joey had mentioned room sharing for the first 6 months is recommended to help facilitate breastfeeding, but not bed sharing. But there isn't a specific age cutoff where it's okay, now we do recommend bed sharing versus not. So I don't think there's good guidelines for that. I think generally being able to assess the development of the child, can they roll over on their own? Could they how mobile are they, things like that, but there isn't a recommended age where it's now considered safe. The only time we have an age is for the bed room sharing versus bed sharing. And I don't know if we have numbers specifically for breastfed children that are co-sleeping. And it's also very hard to define bed sharing and room sharing. And some of those definitions also get a little bit lost. For example, I was looking into, Japan has one of the lowest rates of SIDS, I think, from Joey's data. And they are one of the countries that do have higher rates of bed sharing, except in those specific, what they've included in that definition is parents who keep a bamboo bassinet on the bed with them. So the baby isn't physically in the bed with the parent in the bed sheets, but they are in their own bassinet on the bed beside the parent. So they classified that as bed sharing. So the definitions get a little bit hard to quantify, so it's hard to compare some of those numbers across different countries as well. So that also confuses things.
So I think we're just about at time. Are there any other questions from the room or online? And if not, I have one question that I was curious about if we had time. Okay, not seeing hands go up. So I was, in terms of the graphs you were showing, in terms of the reductions in the rates of SIDS over time, my area, inborn errors of metabolism, through the 1990s, that's when you were starting to recognize fatty acid oxidation defects as a disease, and one associated with unexplained mortality, right? So there was actually this enthusiasm at the time that maybe we were going to have explanation for a large percentage of kids who are dying of SIDS, which is really a diagnosis of exclusion, right? So, I think some of the and we actually had a long-standing surveillance system in place for any kid who died under the age of 2. We got a blood sample, checked if we were missing those kids from a newborn screening system point of view, and in the end we weren't. So that sunset. But something that's gained more prominence is occult cardiac dysrhythmias, and whether that might be a contributor. Because again, some kids, is this what's the environmental risk versus what's other reasons for unexplained death? So I was particularly curious if you looked into the cardiac dysrhythmia story, and it's not one I've looked into, but is this do we have better data as to whether this is a contributor in a subset of the SIDS population or not?
I'm not sure what you found, Joey. I didn't find anything specific. And like we were mentioning with the definition of SIDS, it's so dependent on what investigations are actually done post-mortem. Like lots of our data is autopsy data, which is not perfect and not everybody gets included. So I can't speak specifically to the cardiac bit.
Yeah, I didn't find specific numbers for sort of like there's an umbrella diagnosis of SUDI, which is sudden unexpected death in infancy, that then gets broken down, and you have to have in Canada and places that can afford to do it, you have to have a full, thorough investigation with a death scene investigation and an autopsy for a death to actually be ruled as SIDS officially. And there is a question. So without naming specific diagnoses, there's a question in the public health data of is some of the drop in SIDS rate that's being seen because post-autopsy diagnoses, like diagnostic ability is so much better and more informed, and we're catching dysrhythmias and metabolic disorders and CNS disorders that weren't caught previously. And these deaths that were previously classified as SIDS are now like still in the SUDI umbrella, but go somewhere else. And that could be causing part of this drop in SIDS incidence. And I think it probably does play a role in the dropping incidence. I just didn't see any specific numbers for specific diagnoses.
Yep. Okay, great. Thank you. Thank you again for the presentation, including Joey and Satch online. And yeah, someone was about to clap, so that's a good cue to